Everyone, and welcome to Fearless Friday. My name is Joy Rustoven, and I am the Executive Director of Survive It. Today, we're going to talk a little bit about the 3 things that you should know about your cancer. Most people we find just, they say I have stage 3 colon cancer or stage 2 prostate, stage 4 lung, and they think that that's all they need to really know about their cancer. But the reality is, with the advances that we've had in the last 5 to 10 years, and the rate at which we are progressing in the world of cancer, you do need to know a bit more if you're going to be engaged and advocate for yourself appropriately. So I'm pleased to introduce our guest today. His name is Dr. Reddy, and he is the Vice President of Medical Affairs at Foundation Medicine. Welcome, Dr. Reddy.
Thank you, Joy. It's a pleasure to be here.
So are you still a practicing physician, or did you leave that behind when you moved to Foundation Medicine?
I have been a practicing hematology and oncology physician for about the past 10 years. I joined Foundation Medicine in 2016, and I am still involved in patient care, but not nearly, as much as I was when I was doing day-to-day clinic.
Well, I think that you're the perfect person to talk about this, since you have that experience with patients and caregivers, but you're also working at Foundation Medicine now. So you're seeing both sides. And so I want to jump right into it. And let's start with, what do I have?
Absolutely, Joy. So, every cancer is unique to every single individual. So everything starts with, what do I, as an individual patient, have? And so at the very basic level, we're talking about a patient's diagnosis. And so as we know today, when we talk about a diagnosis, it's more than just where the cancer started. So in today's world, it's not just I have lung cancer or I have breast cancer. In today's world, we really need to identify the biomarkers or the genomic information, the molecular information associated with that patient's cancer. The reason why this is so important is because we now know that cancer is really a disease of the genome, or the underlying genetic material that is driving that cancer. And so at a very basic level, we don't want to think about lung cancer as just lung cancer.
So we're taking it beyond where they found it and the stage that your oncologist assigned to it, correct?
That is correct. So when we talk about this molecular information or the genomics information, nowadays we don't talk about, say, lung cancer. We don't talk about small cell lung cancer versus non-small cell lung cancer. It's just as important today to understand the molecular information based on genomic testing, such as, do I have an EGFR alteration, or do I have an ALT alteration, or do I have a ROS1 alteration? And that list of molecularly defining that patient's non-small cell lung cancer is just getting larger and larger and larger, meaning that these details are becoming more and more complicated, and the only way we're going to understand those details appropriately is to not only just do comprehensive genomic profiling, but ensure that the testing is something that I can trust, so I know exactly what the molecular information that's driving my cancer is, and then I can believe that when I say I have something, I know I have it, and when I say I don't have something, I know I don't have it. Both of those are just as important.
Mm-hmm. And so why is it important to know your molecular signature or your mutation or alteration? I know there's quite a few names out there that people give to it, but why is it important to know that? Does it affect your treatment options? What does it tell your doctor?
Absolutely, Joy. So in today's world, it really impacts 3 big things. One is the diagnosis itself. Right? So in today's world, if I'm EGFR positive, that's part of my diagnosis. I have non-small cell lung cancer that's EGFR positive. That's part of my diagnosis. That can also impact, for example, my prognosis. And so my prognosis, say I have a TP53 alteration. There's a number of genomic alterations that, regardless of the treatment, everything else being equal, it describes just the underlying biology of the cancer. Is this a cancer that's more likely to behave aggressively, or maybe a cancer that's less likely to behave aggressively? And then the last big bucket is those therapeutic associations that are so important. And so those therapeutic associations means which tools can I put in my toolbox? And so based on these molecular tests, then maybe tools that weren't in my toolbox, I can now put in my toolbox because I know I have drugs that work when I have that particular alteration. And that's probably the other major sea change that's happened over the past 10, 20 years especially, and certainly over the last few years, it's accelerated. But this idea of who cares if I get a test to identify something if I can't do anything about it? Well, what we can now say today is we can do something about it for a great number of patients. And so, for example, in non-small cell lung cancer, we have great drugs now that are, EGFR inhibitors or ALK inhibitors or ROS inhibitors or MET inhibitors or TRAC inhibitors, and the list gets longer every single day.
Can you give us an example of, I like that analogy there, that after having this test done, you know what tools you can now use that you may not have thought that you could. So can you give us a real world example of what that actually looks like?
Yeah, at the simplest level, everything starts with testing. So there's this thought process that if I get a test and say my report is negative, meaning that there were no alterations that were identified that brought a tool into my toolbox, does that mean that test was a waste? And the answer is no. So for example, if I'm just going to go back to lung cancer because that's probably the disease that we have the most data on in using a genomics or molecular precision medicine approach. But say I have non-small cell lung cancer, 100% of patients should be tested for EGFR. And unfortunately, the reality is only 70 to 80% of patients are even being tested for EGFR, even though they may have metastatic non-small cell lung cancer. It should be 100%. But say I get tested and I'm EGFR negative, and let me just expand that. Say that there were no targeted options. Say I was EGFR negative, ALK negative, NTRK negative, etc. It's still not a wasted test. The reason why it's not a wasted test is it still helps me with my underlying diagnosis, and it helps me as a patient and my physician make the best treatment choice based on the most complete information. It may be that I need to use chemotherapy. It may be that I don't have any of these single gene alterations that would lead to a targeted therapy approach with, say, an EGFR inhibitor, but perhaps I can use an immunotherapy, or perhaps I can use a chemotherapy regimen that is the standard of care when you don't have these alterations. That's why it's so critical. Whether the test is positive or not, it is an important thing to go through so you know as much as you can about your cancer, and so you and your physician can make the most appropriate treatment decision with as complete information of your cancer as you can get.
I know that, a cancer diagnosis, and when you're in the thick of it, it's just so overwhelming and there's so much information coming at you. So you simplifying this down into what do I have? I think that's a really good jumping off point for a lot of people. So we appreciate you being here today.
Thank you, Joy. Appreciate it. Pleasure to be on.
Thanks, everyone. We hope this was very helpful for you and your loved ones. And as we always say, stay strong and live fearless.